So we're going to be talking about the Knosp classification of cavernous sinus extension of pituitary lesions. And so when you have a pituitary adenoma, it has two ways it can grow. And of course, tumors are going to take the path of least resistance. So here's the sella turcica, and inside is the pituitary gland, then this pituitary stalk, and then the chiasm is above it. So normally when you have a pituitary adenoma, he just wants to go straight up and hit the body of the chiasm and produce bitemporal hemianopsia or optic neuropathy, or hit the tract and cause homonymous hemianopsia. However, to either side laterally is the cavernous sinus. And in the cavernous sinus, of course, live the cranial nerves 3, 4, 5, subdivision 1 and 2, and cranial nerve 6, as well as the internal carotid artery. And so the Knosp classification, when you have pituitary adenomas that extend laterally, give us some indication about how far laterally the tumor has grown. And so if it gets to the carotid, we'd like to know, is it medial at the midline or lateral to the internal carotid artery? And that is the Knosp classification. And the reason it's important is when you do a transsphenoidal surgery, they can get a gross total resection if the tumor is medial to the carotid. But once the tumor starts getting around to the lateral side of the carotid, like Knosp 3, B, or 4, it's going to get harder and harder for them to get over there. And so the chance of a gross total resection, especially via a transsphenoidal approach, once you get past the midline of the tangential line between the internal carotid arteries, is going to be less and less. And so what we're trying to do is prevent the tumor from getting over there to begin with by operating on it when it's surgically resectable, if the person's a good surgical candidate, and recognizing that once it's on this side of the carotid, the lateral side, we're probably not going to get a gross total resection without causing significant morbidity. And so those patients might end up with radiation therapy. And so from a neuro-op standpoint, we need to recognize both the suprasellar presentation, which is vision loss on the afferent side, but the efferent presentations, ophthalmoplegia, Horner syndrome, 3rd, 4th, 6th nerve palsy, and correlate that with clinical radiologic correlation against the Knosp classification. How far laterally are we relative to the internal carotid artery? Because that gives us some prognostic information about surgical resectability and the possible need for adjunctive radiation therapy following subtotal resection.